Dr. Neha, please start.
Good evening, all the respected dignitaries, seniors, and colleagues. I, Dr. Neha Singh, editor of Raigad IP and Secretary AHA Raigad, on behalf of Maha IP and IP Raigad, I welcome you all to the first day of April. Yes, the day of our general reading. I welcome Maha IP President Dr. Sanjay Pakmore sir, Secretary General Dr. Amol Pawar sir, State Convener Dr. Sanjay Deshmukh sir, Dr. Praveen Gokhale, Dr. Minaj Sheikh, Raigad IP President Dr. Vikas More, Secretary Dr. Ajay Kohli, respected Dr. Neeman Mohanty sir, Jay Bhandarkar sir, and all the respected executive board members from Maha IP, Raigad IP, as well as other branches. I'm extremely delighted to welcome our esteemed experts of today, Dr. Vishnu Viradar sir and Dr. Sampada Tambolkar ma'am. I also welcome our presenters of today, Dr. Manali Srivastava and Dr. Vishal Vasudi. Today, I invite, first of all, I would like to invite President Sir, Dr. Sanjay Pakmore sir, to please give his blessings. Over to you, sir.
Sir,
Sir,
please
kindly
unmute.
unmute.
Sir, kindly unmute.
Namaskar. Good evening, all. Yesterday only, 2 days back only, we have done Happy Gudi Padwa to you all, and we have done the biggest thing in the history of IAP, that is we passed the CRC with you unanimously, and that too in a very good environment. So yeah, I just wanted to share with you all of you. Now, today's program, Journal Journey, which we do, which means Journal Journey is generally on the first day of every month, and this is academic activity which gives push for all the academic activities in that particular month. So it's a very good thing by Raigad IP and with the Maha IP. Really started with the start of the year. Every year with the with the start of the first days begins with the academic activities, that is the journal journey. And I may thank, I would like to thank Dr. Mohanty sir for this contribution and Raigad branch for their contribution for this particular innovative program, which has been done by all the last 3-4 all the past presidents of last 3-4 years. And even we continued in this year, because this is one of the wonderful activity everybody would like to do, continue in his tenure only. So I must thank all the office bearers of the Raigad IP, and I also welcome Vishnu Viradar sir and Sampada Tambolkar madam, which are the today's experts, and the presenters Manali Srivastava and Dr. Vishal Vasudi from the Ashwini Medical College, Solapur. So over to Neha ma'am.
Thank you so much, sir. Now I invite Dr. Amol Pawar sir to say a few words. Over to you, sir.
Thank you, dear Neha. So Raigad IP is doing this journal journey activity since last 3.5 months. Everything has been already explained by sir. 2 days back we passed the CRC, and almost 70 to 80 Maharashtra IP members came to special GBM, which happened in Nagpur, and all we will be going to Charity Commissioner with all these recommendations and the draft, and we will be continuing whatever there was demand of democracy and elections in Maharashtra. It will happen this year. And next thing is this journal journey is very good initiative, and Dr. our Vikas More sir, Ajay Kohli sir, President and Secretary of Raigad IP, they are continuing this activity, which was started by Dr. Gangulia sir, Dr. Jay Bhandarkar sir, Dr. Chitra ma'am, Dr. Neeman Mohanty sir, the main backbone of this, and Dr. Neha, she is continuously helping them all. And today we have none other than Dr. Vishnu Viradar, one of the leading pediatric gastroenterologist and hepatologist from Pune, and also other expert, Dr. Sampada Tambolkar ma'am from professor at D.Y. Patil, and all the best to her husband, Dr. Ajit Tambolkar sir, who is standing for MMC elections, which will take place in 2 days' time. and also Dr. Madhuri and Dr. think the other one, Dr. Manali and Dr. Vishal. They are from Ashwini Medical College, Solapur. So I wish all the best to both of them in their presentation and wish you all happy learning. Thank you.
Thank you, Amol sir. Now I invite Sanjay Deshmukh sir to say a few words. Over to you, sir.
Good evening. Firstly, on behalf of MahaIP as a convener, I welcome you all to this academic activity on General Meet, which happens to be on the first day of every month. Though today is 1st April, April Fool Day, but Maharashtra academic never make fool to anybody. The academic will continue. So hats up to IIP Raigad for continuing this trade. And I welcome you all. And today we have two interesting presenters, the dynamic pediatricians, Dr. Manali Srivastav and Dr. Vishal Bhusari is from Solapur. And we have expert Dr. Vishnu Biradar and Dr. Sampata Tambulkar ma'am from Pune. So I hope this journey will continue, and my best wishes to IIP Raigad and MahaIP for the general meet. Thank you.
Thank you, Dr. Sanjay Pakmode sir, Dr. Amol Pawar sir, and Dr. Sanjay Deshmukh sir for all the encouragement and blessings. Now I would want to invite Raigad IIP President Dr. Vikas More sir to say a few words. Over to you, sir.
Thank you, Neha, for inviting me. At the outset, I am very much thankful to respected Dr. Sanjay Pakmode sir, President MahaIP, Dr. Amol Pawar sir, and respected Dr. Sanjay Deshmukh sir, who are a constant backbone of support behind IIP Raigad to do all these activities. And more of my best friend, Dr. Vishnu Biradar, for accepting to be an expert. I was his room partner, so he's very close to me. And Dr. Sampata Tamulkar madam from Pune. And the young presenters from Solapur, Dr. Manali and Dr. Vishal. I'm best of luck for them to give a nice presentation. We know that the idea behind starting this particular journey is because we know that a strong foundation in academics enhances not only the patient care, it also supports the professional growth and also contributes to the progress of a pediatrics as a field. So, for a practicing pediatrician, the continuous learning is not just an option, but it is a necessity, providing a optimal and up-to-date medical care. So that is absolutely essential to be in touch with ongoing updates, and it is not a option. You have to be updated in these days. So with this idea in mind, our respected Dr. Niman Mohanty sir and Dr. Chitra Kulkarni madam consistently working hard since years. And I'm especially thankful to Dr. Minash Sheikh sir for being a support, very continuous support for us. And I appreciate the presence of Dr. Pravin Gokhale sir. And there are many respected people who have joined today. We are so proud and fortunate that the people from all over Maharashtra, not only all over India, are joining. And this is really taking in a good way. And we hope that we will do this service consistently to MahaIP in future also. Thank you so much. Over to Neha.
Thank you, Vikas sir. So, reciting the famous lines of David Bohm, the ability to perceive or think differently is more important than the knowledge gained. So now I invite Raigad IIP Senior Pediatrician and Chairperson-elect Maha AHA Dr. Chitra Kulkarni ma'am to please introduce our experts and presenters of today's journal journey. Ma'am, over to you.
Yeah, thank you very much, Dr. Neha. Our first expert, Dr. Vishnu Biradar, is pediatric gastroenterologist and hepatologist working in Ruby Hall and other famous hospitals in Pune and Navi Mumbai MGM. He has been bestowed upon by various awards and honors and more than 10 research papers and 5 book chapters. The present review article of study of neonatal liver failure for 30 years. He is one of the co-author. We are very fortunate to get him for our academic journey as an expert today. Welcome, sir. Our second expert is Dr. Sampada Tambolkar. She is Professor of Pediatrics in D.Y. Patil Medical College, Pune, a very well-read and articulate. We will definitely get new insights in the topic of mental health in adolescents. Our presenter is junior resident third year Dr. Manali Srivastava, and very intelligent, as I can see it in her practice sessions. She is from Ashwini Rural Medical College Research Center, Solapur. Our second presenter, her topic is neonatal liver failure. And our second presenter is Dr. Vishal Bhusari from Ashwini Rural Medical College and Research Center. And he will be presenting mental health screening and measurements in children and adolescents. This paper is from, the study is from USA. Over to Dr. Manali. You can start sharing your screen and start your presentation, please. Dr. Manali, please unmute also.
Thank you so much, ma'am. Good evening, everyone.
Full screen. Yeah.
Good evening, everyone. I'm Dr. Manali Srivastava, junior resident in Ashwini Solapur Medical College. My topic for journal presentation is neonatal liver failure. The journal was published in the Journal of Pediatrics in August 2024 with the title Etiology, Characteristics and Outcomes of Neonatal Liver Failure Learned Over the Last 3 Decades. It was conducted from the liver unit including small bowel transplant, Birmingham Women's and Children's Hospital, United Kingdom, and Pediatric Gastroenterology and Hepatology, Jupiter Hospital, Pune, Maharashtra, India. The objective was to evaluate trends in etiology and outcomes of neonatal liver failure over 30 years retrospectively at a single institution. The impact factor of this journal in 2024 was 3.9. A comprehensive retrospective study examining 30 years of data on neonatal liver failure from a single institution. This research by Calgary et al. Analyzes trends in etiology, outcomes, and risk factors for poor outcomes in babies presenting with liver failure within the first years of between 1991 and 2020. Acute liver failure introduction. Acute liver failure, although rare, should be suspected in all sick neonates as it can rapidly progress to multi-organ failure and death. The Pediatric Acute Liver Failure Study Group defines ALF as liver-based coagulopathy, unresponsive to vitamin K with PT more than 15 seconds or INR more than 1.5 with encephalopathy, or PT more than 20 seconds or INR more than 2 without encephalopathy. Given the challenges of diagnosing encephalopathy in neonates, most studies use PT more than 20 seconds or INR more than 2 as the definition of neonatal liver failure. A prompt comprehensive workup is undertaken to diagnose treatable etiology and prognosticate the clinical course while providing supportive care and timely consideration for liver transplantation. The study design and methodology, inclusion criteria were babies presenting at less than 28 days of age between 1991 and 2020 with PT more than 20 seconds and biochemical liver injury. The data collection, demographics, etiology, laboratory investigations, need for extrahepatic organ transport, acute kidney injury, and intervention with liver transplant were recorded. The study period was stratified into 3 10-year blocks to analyze trends in hospital admissions, etiology, and survival outcomes. The survival outcomes were measures for patients with liver transplantation or after liver transplantation. The etiology, characteristics, and outcomes of neonatal liver failure. This presentation evaluates trends in etiology and outcome of neonatal liver failure over 30 years at a single institution. The study includes babies presenting at more than 28 days between 1991 and 2020 with PT more than 20 seconds and biochemical liver injury. Survival outcomes were measured as discharged from the hospital alive with native liver or liver transplantation.
The diagnostic evaluation and management, evolution of diagnostics, availability of polymerase chain reactions for diagnosis of viral infections, increasing access to MRI and MRS and genetic testing. Evolution of medical management, recognizing neonatal hepatitis as a phenotype, use of intravenous immunoglobulin and exchange transfusion in gestational alloimmune liver disease, conservatory fluid strategies, evolution of ICU care with USG guided vascular access and invasive hemodynamic monitoring. Evolution in liver transplant surgical techniques, availability of microsurgical instruments, including vascular clamps and hemostatic devices, high-resolution imaging to plan surgeries, use of intraoperative ultrasound and Dopplers, use of recipient size appropriate reduced and monosegment liver grafts. The patient's demographics and etiology. As from this pie diagram, you can see that the most common causes for neonatal liver failure come to be infectious, indeterminate, and metabolic, which were the most common causes. Like 29% of infectious, 25.4% of indeterminate, and 24.6% of metabolic. Increasing hospital admissions and changing etiology trends. Increased admissions, hospital admissions for neonatal liver failure increased from 21 in 1991 to 2000 to 65 in 2011 to 2020, indicating a growing need for specialized care. Etiology trends, there was an increasing trend in infectious and metabolic causes, while a decreasing trend in indeterminate etiology was noted over the 3 decades. Specific causes, the rise in metabolic disorders and herpes simplex virus related neonatal liver failure significantly contributed to the increase in hospital admissions. As you can see from the trends from each of the 10-year block, the metabolic causes increased from 4.8% in 1991 to 2000 to 24.6 in 2011 to 2020 era. The hospital admissions also increased. As you can see, there is an increasing trend, 21 total admissions to 40 total admissions in the second block to 65 total admissions in the third block. Laboratory parameters and diagnostic markers. HSV and infections, high prothrombin time with high transaminases. Ferritin was highest in HLH and infection, low AFP levels. In gestational alloimmune liver disease, high PT with near normal transaminases. MRI abdomen demonstrated pancreatic iron deposition in 6 out of 7 cases, higher AFP levels. In metabolic and HLH, modest elevation of prothrombin time and transaminases. AFP was lower in babies with HLH. Genetic testing facilitated diagnosis in 12 babies. The essential diagnostic test for infants under 3 months can include a serum amino acid profile to detect urea cycle and other metabolic defects, ferritin for GALD screen, lactate and pyruvate for mitochondrial screening, plasma acyl carnitine profile for fatty acid oxidation defects, urine succinyl acetone for tyrosinemia, enterovirus blood PCR for systemic enterovirus infection, drug history for exposure to any herbal dietary supplement, confirm newborn screen results to rule out galactosemia and tyrosinemia, confirm maternal hepatitis B serology for hepatitis B in newborn. The diagnostic procedures and additional testing included abdominal ultrasound with Doppler to rule out vascular anomalies, echocardiogram to rule out cardiac dysfunction, blood culture to know about sepsis, viral testing for adenovirus, enterovirus, HHV6, parvovirus, and influenza. Additional test includes hepatitis E IgM for hepatitis E, soluble interleukin-2R ferritin triglyceride level for HLH, liver copper Wilson gene mutation analysis for Wilson disease, MRI for extrahepatic iron deposition in GALT, and urine orotic acid for urea cycle defect. The survival outcomes and mortality trends, the overall mortality was 42.9%. In era 1, it was 52.4%. In era 2, it was 50%. And in era 3, it was 35.4%. We can see that there is a decreasing trend in the mortality rate. The improved survival with native liver and reduced mortality. There was a survival with native liver improved significantly from 23.8% in 1991 to 55.4% in 2011, showcasing advancements in treatments. The mortality rates decreased from 52.4% to 35.4% during the same period, reflecting enhanced supportive care and management strategies. The liver transplant, 23 neonates received liver transplant, contributing to improved survival outcomes in specific etiologies. The risk factors influencing mortality in neonatal liver failure is specific etiology. Gestational alloimmune liver disorder was associated with lower odds of death. Patients presenting with acute kidney injury significantly increased the mortality risk. And if there was a need for inotropes, that also increased the risk for mortality. The risk factors for poor outcomes, as we have already discussed, is acute kidney injury, need for inotropes, ventilator supports. The evolution of diagnostics and management of NLF, evolution of diagnostics, availability of PCR for viral infections, and increasing access to MRI, MRS, and genetic testing. Evolution of medical management recognizing neonatal hepatitis as a phenotype, use of intravenous IVIG or exchange transfusion in GARD, conservatory fluid strategies. Availability of microsurgical instruments, high resolution imaging, and use of intraoperative ultrasound and Dopplers. The key findings and implications for clinical practice: improved survival, advances in diagnostics, treatment, and increasing experience with liver transplantation have improved survival in neonatal liver failure. Etiology matters. Specific etiologies significantly influence the outcomes, with GARD showing favorable post-LT survival and HSV NLF remaining a challenge. Extrahepatic organ failure, presence of AKI, and need for inotropes are critical risk factors for mortality, emphasizing the importance of multi-organ support. Transplant considerations: liver transplantation remains a life-saving option, but careful selection is crucial, especially in HSV neonatal liver failure cases. Conclusion: advancing care for neonatal liver failure in the last 30 years, advances in diagnosis, treatment, and increasing experience with liver transplantation have improved survival in neonatal liver failure. The study highlights the importance of early diagnosis, etiological specific management, and multi-organ support to improve the outcomes. Further research and multi-center studies are needed to refine treatment strategies and improve survival rates in challenging cases like HSV neonatal liver failure. Thank you.
Thank you, Dr. Sampada, for such a lucid presentation. Will you please stop sharing the slides? Over to Dr. Vishnu Biradar, sir.
Yeah, Manali, fantastic job. It was such a difficult topic because getting to know about neonatal liver failure is a difficult thing. Uh, Actually, this pediatric acute liver failure like definition which was used for segregating these cases, but I remember correctly that the maximum PTINR recorded or the average maximum PTINR recorded was more than 6.5 in almost all cases. If you remember, for a pediatrician and for us as a clinician, what we need is that out of 123 patients, 21 were galactosemias. So this 21 is almost 15 to 20% of neonatal liver failure. And this is the subset which doesn't require any drug treatment or any liver transplant. This is just managing with the dietary restriction of the milk and milk products. The child improves. So this is one thing which I think everybody should take away from. The message should be very clear that this is the treatable cause and this should not be missed. It is very simple to diagnose, like by doing a urine non-glucose reducing substance, like doing the dipstick method. If the dipstick method glucose is negative, then sending this sample for Benedict. And if the Benedict is positive, that means a non-glucose reducing substance is present. And the second test, which is important, is GALT enzyme. So any child with neonatal liver failure, we should not miss it. It is very simple to understand that only bilirubin is very high, SGOT, SGPT is normal, and the coagulopathy is very high. So when we do the liver function test and only bilirubin is high and SGOT is normal, and if we don't do the prothrombin time, we will miss these cases because the prothrombin time in these patients will be very high. The second category, which has a very catastrophic outcome, was the herpes simplex. It was very painful to see that without transplant, with the acyclovir and the antiviral also, they don't improve. And with the transplant, after giving antiviral, post-transplant, also this viremia was persistent, and these children did very, very worse amongst all the lot. For a clinician, the difficult part is if you don't have a galactosemia, if you don't have a particular metabolic, like some of the cases where OTC deficiencies, some of the cases where Niemann-Pick, some of the cases where Gaucher, some of the cases where GALT. So GALT is very simple to understand that the 90s eras, they used to do the lip biopsies to see the iron in that. But as the advancement of MRI came into the picture, and they could able to do the MRI of ventilated newborn in their setting. That is the beauty of that setup. So pancreatic iron deposition, if it is very high, then suspicion of gall, and then they treat it with the first they started treating with a cocktail regimen in 90s, then they switch over to the exchange transfusion, and the later part it was IVIG, and the response is good with those, and some of these are also underwent a transplant. So the last, the subset, which is very, very difficult to diagnose, was a mitochondrial disease. So because of the lack of the uh, the words, it could not have been specified, but I remembered it very clearly. The lactates were very high in those who are the mitochondrial disease and those who don't have the mitochondrial disease. So that was one of the differentiator between the other disease and the mitochondrial. And obviously they have this advancement of doing, initially they used to do the electron microscopy of the mitochondria, and then the genetic studies, which in India we started getting now in 2014-15. So they were doing genetics in 1990, and they were doing the mitochondrial genome also in those era. So that much advancement was there. So if you look at the India now, we can able to do the viral PCRs, not only the herpes, but we do the enteroviruses. Chikungunya is very common in our setup, or we get a lot of rickets cell disease presenting with liver failure in this particular. So now we are getting this in last, say, a decade or so. We can able to do the MRI, but doing a MRI in the newborn is still a challenge in our setup. Genetics is not freely available. It's costly, but still it is available now. And mitochondrial and the exon sequence both are available, which is boon for us. But the problem is that it takes 1 month the report to come. So very high suspicion mitochondria, we don't transplant them, because doing a transplant, because there also we see that neonatal liver failure did the transplant, later on the genetic came as a mitochondrial, and these children did worse. So some of these children died at 2 years, some of them died in a year of liver transplant. So these are the takeaway from this article. And tyrosinemia is very small proportion. So neonatal liver failure, we always think of galactosemia, infection, mitochondrial, gestational albumin, and the rare varieties which we don't know, which we call as a indeterminate. That is, as a clinician, I think this message given well by the Manali. The results are good. Even we have started doing the neonatal liver transplants in India. There are good centers, and in Pune and Mumbai also, we are doing the liver transplant in younger child, 3 kgs, 3.5 kgs, 4 kgs. So we are catching up with the standards of European standards and the international standards now.
Thank you, sir. Thank you very much. And it was an interesting elaboration of your own study. We are happy for that. And for general pediatricians like us, you have told the common things which we will remember it forever. Now we move forward for the second presentation. I invite Dr. Vishal Busari for his paper of mental health screening in adolescents. Dr. Vishal? Can we see it full screen?
Yes, ma'am. Hello, good evening, everyone. Am I audible?
Yes.
Good evening, everyone. My today's journal topic is mental health screening and the measurement in children and adolescents. The authors of the journal are Mary Reilly, MD, and Carol Wiesman, MD. The journal is from Pediatric Clinic of North America. The impact factor of journal is 6.2 in 2023. Now, background. 20% of the children aged less than 17 have mental health issue. 40% will meet the criteria for mental health disease by the age of 18 years. ADHD and the anxiety affects around 20% of the children. 20% of adolescent youth experience a major depressive episode by the age of 18. Suicide is the second leading cause of death in US among the age group of 10 years to 24 years of age. Then barriers for the screen. There is a limited training in primary care physicians. There is personal discomfort, time constraints, electronic medical record limitations are there. There is lack of adequate tools, not knowing how to interpret positive mental health screen or how to explain the meaning of the result is also a major barrier to the screening. Then current state of detection. The this screening is not routinely detected in primary care setting. The standardized screening tool significantly improves the identification of areas of concern. Screening addresses the equity issue as well as it reduces the implicit biases. Then standardized screening measures. Screening should not occur in isolation. Successful screening depend on the sensitivity, specificity, as well as the positive predictive value and the negative predictive value. Primary care clinician need to be aware of the socio-demographic characteristic of the population. And there should not be a single measure which is appropriate for the children of all ages. Now some definition. Sensitivity, it is to detect those who have the condition. Then specificity, to detect those who do not have the condition. Then there is positive predictive value, which signify that the screen is probably that youth with the positive screen actually have the condition. Then negative predictive value is the probability that the youth with the negative screen does not have the condition. Then current screening recommendations. Screening should begin in the first year of age. Then pediatric clinicians need to select the screening tool that is feasible as well as appropriate for their practice. Now some commonly available mental health screening tools. For general mental, emotional, and behavioral concern, we have pediatric symptom checklist, that is PSC, the strength and the difficult questionnaire. Then for anxiety and depression, we have screen for children anxiety related disorder, SACRED, the generalized anxiety disorder 7, GAD 7 scale. Then for suicide, we have adapted sad person tool. Then there is ask suicide screening questions. Then for ADHD, we have ADHD rating scale 5 and Vanderbilt diagnostic rating scale. Then for maternal depression, we have Edinburgh postnatal depression scale. Now some clinical care points. High rates of children have mental health issues. The AAP recommend the global and domain specific screening. Anxiety screening should start after 8 years of age. Depression and suicide screening should start after the age of 12. Then selection and screening measure based on their feasibility and appropriateness should be done. And screening results should trigger a conversation. Children who screen positive for suicide must be assessed for their risk. Then key findings of the journal. First finding is screening improves the early detection. It reduces the implicit biases. It enhances the clinician and family relationships. Early intervention improves the outcomes. And this study also signifies the ongoing need for the surveillance. Then the strength of the studies, the comprehensive review of screening tool is there. It advocates the early intervention. It provides the practical guidelines for the primary care physicians. It is equity focused and addresses the disparities. And it also contextualizes the impact of COVID-19. Shortcomings of the study, limited long-term outcome data is available. The over reliance on screening tools is there. The study is mainly done in US, so US centric finding limits the global applicability. Then there is insufficient focus on implementation and needs more digital screening research. Conclusion: mental health crisis need urgent action. Routine screening enhances the early detection, addresses the barrier for effective implementations, focuses on equity, access, and intervention. Future: integrate tech, improve global relevance. Then what is known and what this study adds? What is known? High prevalence of mental health issues. Early detection improves the outcome. What this study adds? Updated screening guidelines, emphasizes on reducing biases, and practical integration into the primary care. Now carry home messages. Mental health screening is crucial, and early intervention improves the outcomes, addresses the barrier to better access, uses the standardized tool, integrate the technology for the efficiency. Now, relevance of this study in Indian context. First, there is a rising mental health concern among Indian population also, increasing issue among children and adolescents. Key factors are academic pressure, social media, competition, and family expectation. 7.3% adolescent affected at low help seeking. Then the second relevance is barrier to screening. There is a lot of stigma and there is low awareness among Indian population. Mental health is considered as taboo. There is limited access because there are few trained professionals, especially in rural areas. There is also language barrier. Many tools are not in regional languages. Then importance of early screening, routine checkup help in early intervention. School can be a key screening hubs. Then implementation challenges. Time constraint is the important implementation challenge. Pediatrician in India usually handle high patient load. Then system integration is not widely used in India. EMRs are not widely used. Then there is lack of training. Need of pediatric mental health education is there. Then there is opportunity for adoption. There is opportunity can be in the form of traditional support. We can engage families and communities. Take support solution app and consultation can be used for the screening. Then we can integrate opportunities in school program like health checkups and all. Then we can also make policy level changes, like we can integrate these changes in Rashtriya Bal Swasthya Karyakram for wider coverage, and we can train pediatrician and school counselor for the early detection. Thank you, everyone.
Thank you very much. It was a clear and simple language presentation. We really appreciate you, Dr. Vishal. And now we are eagerly waiting for the expert comments by Dr. Sampada. Over to you, ma'am.
Thank you, ma'am. A very lucid presentation, Dr. Vishal. So congratulations for that. And it made my job very, very easy. Now, looking at the adolescent picture, we are reading a PCNA article and how does it actually help us? It's like, what is in it for me as an Indian pediatrician? Well, the data I don't think is different from what the US data shows. If you look at the mental health population, health issues population in the US, it's showing about 20%. If you look at the Indian population, it is roughly 14 to 20%. And that is also when you have a large amount of underreporting as far as data is concerned in India. So if you look at India, it's a geographical and a demographic pool that we have. So we have two categories there in the Indian data. You have an urban and you have a rural category. And like all diseases, we say that, health issues are more in the rural category. Here, the data which is recorded in the National Health Mental Health Survey, it's showing a 14% rural health problems, mental health problems in the rural community, and urban slums, it's reporting around 25 to 30%. Now, I think that is more to do with lack of data availability, lack of screening, and lack of awareness in the rural community. That is one thing that we have to take back home, is that actually we are talking about data, but are you really looking at the larger picture? Do you really have something which is going deep down in collecting data? That is one thing. The most alarming thing about what Indian studies is saying is that we did a 5-year plan from 1995 to 1999, which was showing a suicide rate in the adolescents of 7%. Unfortunately, the cause of death in adolescents in the 2016-21 family welfare data is showing 47%. So look at the steep rise from 7% to 47%. Did a project last year with the government, with the medical college students, and I was shocked to know there were 581 deaths only in undergraduates in the medical students from first year to third year in the period between 2019 to 2022. So what are we actually looking at? Are we missing the bus somewhere? And what do we really have to look at? So first of all, what Dr. Vishal did mention is that when we say start screening, is like early means how much? How early can we go? I think in the Indian context where we have such a robust system of immunization, both in the government setup as well as in the private, because we are catering to about 5 to 10% the private, 95% to 90% to 95% is catered by the government. I think for screening, it should start in the first 6 months. And then you will say, what are we going to look at the mental health? Look at the mental health of the mother. If the mother is suffering from mental health issues, there are two things to it. One is it's going to affect her lactation, number one. And that's going to have a negative outcome as well. And two, what it is going to add also is that, is there a family risk involved? Because the mental health issues in the child who has a one parent affected is to the tune of 50%. So that's how early we are going to start. So if we time our mental health screening with our immunization visits, I think that would be great. So we start as early as 6 months. You can add like the influenza vaccine. Why compare it with the vaccine is because you do it yearly. So like you take a yearly influenza, you do a yearly mental health screening. So I always say it is important, meaning influenza mental health program. So IMP. So go it together, put it together. So yearly mental health screening. Now we are going to ask, how is the mental health going to be assessed? So it's very simple. Divide your age groups into 3 parts. It's less than 2 years, 2 years to 7 years, 7 years to 12 years, and 12 years and above. So if you have 2 years to 7 years, so basic immunization is done, and now the child has come to you at your 4.5, 5 years practicing. It comes for your DPT boosters immunizations. That is a time when you do a screening of the mother as well as you do a screening of the baby, and here you are going to apply a test which is called as a global screening test. It's a beautiful test which has a 9-point scale, very simple. Now the point is that a pediatrician has so many more things to do. Who can do it? Your receptionist can administer that test. It's just a 9-point test. You have helpers in your practice, busy practice. You can give it in the urban setup. When you have a tech savvy mother, you can just administer it to her while she's sitting in as a Google link. So that's how easy it is. The reason why it has to be done is because it has a very high positive predictive value of later ages anxiety. So if you have a global screening test coming positive, it is a 2 times red flag that you are going to encounter an anxiety, which if overlooked is going to boil down to depression and suicidal ideations later on. So after the age of about 7 years, what you do is again a yearly screening, but here you add another test to it. So after the global, what you always have to add at 7 years is an anxiety test, which is developed as a NIMHANS anxiety. It's developed by NIMHANS for Indian children. It's NIMHANS anxiety test. So you do 2 tests that time, one for anxiety, or you can use the anxiety test that's called as GAD-7, which is a European test, but yes, can be applicable for Indian children also. So you do 2 tests. You do a global developmental screen and an anxiety test. And if you get a red flag, please do not assume that they do not have suicidal ideations at 7 and 8 years. If you look at their online social networking platform, you have many children who are scrolling websites for and views for how to commit suicide. So that's how early you have to pick them up. So between 7 to 11, if you have a red flag on anxiety, it is always imperative that you do a suicidal screening test at all. And after the age of 12 years, all 4 tests, at least once in 2 years, is mandatory. One is the global to screen for generic problems, and then you do domain specific. That means you do an anxiety, you do a test for depression, and you do a test for suicide. So it's very simple. For every subgroup, you keep on adding one test. Why is the screening test important? The importance is that as a pediatrician, you are not like Durga Mata doing everything together with your 8 hands. It's impossible. The difference between surveillance and screening is that surveillance is a point of contact given by specialists and professionals to look for a disease. So what you as a pediatrician are doing is not screening, you are doing surveillance, and surveillance is something which comes after screening. So the screening begins at home, the screening begins in your waiting room in the OPDs, the screening begins if in the rural population by your ASHA workers, who I think as a part of RBSK are getting mental health also getting incorporated in the RBSK. So that was a take back. I think that is more important. Like Vishal also said, is that yearly we all of us get forms for filling up, for school health. All of us get them, and we what we do is we just take the blood pressure and we kind of stamp it, and we label it as normal. What we can I think do is that take the form, give that screening test to the mother, look for the red flags. If there is a red flag, call the mother back, because I think follow up, because if you get a positive test, you really don't know what to do with that positive test. We either end up sending to a psychologist or a psychiatrist, which is far and few available help. So what you need to do is that if you get more than 3 red flags, there are about 9 red flags available in the test. If you get more than 3 red flags, it is a definitive risk of suicide, and therefore it is important that here keep your confidentiality away, seek
Yes, ma'am.
medical help, the results are better. Because even when you're taking history in as a part of undergraduate and postgraduate teaching, we never ask for mental health history. We always ask for family history, socio-economic history. But where is the mental health history? I think that should be a part of your curriculum. It should be a part of teaching and training. And I think I'm being in the teaching section. I think that's upon me to add to it. And second thing is to enable your professional help in your clinics or in your dispensaries or in your PHCs to screen these children, so that now also Vishal just said that second commonest cause of suicide is mental health issues in the American context, but ours is no different. We are still the third reason for deaths in adolescence is suicides. So if we have to make our future thing fast and appropriate, look at their mental health, look at their social health, because look at not their social platforming but the social health. And I think that's what, otherwise Vishal has summed it up beautifully. Thank you.
Thank you very much, ma'am. And it was really an eye-opener. And there are a lot of take-home points in your expert comments on this paper. And we immensely thank Dr. Mohanty sir for selecting this paper for today's discussion. Now, moving forward, may I request our past national Maharashtra IIP convener, Dr. Jay Bhandarkar, to ask few questions and scroll the chat box. Dr. Jay, please unmute. Please unmute, Dr. Jay. Pallavi ma'am? Yeah.
Yes, yes. Yeah.
And permission is already given.
Yeah. Dr. Jay?
Yes, madam. Chat box.
By the time he scrolls, may I ask one question, Dr. Sampada?
There's no SS
How?
question, but I have one question.
Yeah.
Yes,
In
please.
our like setting, in Indian setting, are the scores that important?
You mean to say
The scores which you have told, so are they that important, or is it one-to-one interaction which is more important?
Well, of course, one-to-one interaction is always useful, because you know that patient right from his 6 months of age, because he's been coming to you and following up. But even at the age of 2 years and 3 years, sometimes you understand there's something wrong in the family dynamic. So there's something wrong at the value level or the ethics level or the social level. So that those are eye catchers, yes. Why I wanted to put this forth is because as a pediatrician or as a clinician, we always say that my clinical acumen is so good that I will not miss it. Now let me put a data to it. The if you take clinical acumen and just history taking, if you look at the sensitivity of the test, it's only 15 to 18%, and the specificity is 70 to 100%, meaning to say that if it's a very gross situation, your clinical acumen will not go wrong. But if it is a milder thing which is blooming like a volcano erupting, you will miss the bus. And therefore I think rather than just sitting on that my clinical acumen is good and I know the family, I think it is better that you sit down, screen. If he passes the test beautifully, great. If he doesn't, at least you know that you have something to dig into and you need to look at this child.
Yeah, I agree totally, because it is said that by doing that score or doing that test, we get a chance for the family and caretakers to come on the same table, and then the discussion can be on the side of an adolescent. I totally agree for that.
Precisely that the talking starts actually.
Yes.
I have one question. I
Yeah.
think
Yes, sir.
that web series Adolescent might have very famous now. Everybody has watched it. It's a contest in a foreign country. Can we relate to in India? How it is affects the social media in adolescents' life?
I'm
Because
sorry, sir. I did not get the question. Can you
I
just
have
repeat?
watched an adolescent serial web series. It's only 4 episodes recently on Netflix.
Uh-huh.
Adolescent.
Uh.
In that specification, social media causes havoc in the adolescent's life.
Yeah.
And
Sir,
they have
actually, I think we are into this cultural hub that India में नहीं हो सकता है. There's nothing that an Indian adolescent doesn't do and watch in social media which an American adolescent doesn't do. It's sometimes just behind the walls, nobody is aware of it. So I think it is high time that we start accepting that our adolescents are as vulnerable as any other adolescent in the world, and just not saying by saying that amche sanskar आहेत. No, that I think sanskar is good, but then I think it is important that we really see and actually put a rationale behind what social media surfing is happening at home, because we see that even 7-year-olds and 8-year-olds, I'm sure you're coming across patients who are actually seeing content which probably would not be right for that age. So I don't think it is a Western problem anymore. It's my kind of, we are a global village now.
whether we have data, right? We have 140.
Unfortunately, sir, we are very good at diagnosing, not reporting. So I think
Yes.
it's for you and me and everyone to start reporting.
Madam, are we taking mental health so seriously in our countries?
I think almost 20 to 30% are below 18 years, right? So huge chunk of adolescents are there, and I think everybody has a mobile and फेक मोबाईल आयडी करून तुम्ही काही पण करू शकता म्हणजे इव्हन फेसबुक म्हणा किंवा इंस्टाग्राम लॉट ऑफ अदर ऍप.
या आजची रिक्वायरमेंट अन्न वस्त्र निवारा मोबाईल असं झालंय.
आपल्याला काय करताना फोन करा कुठेतरी चिठ्ठ्या लिहा आपल्याला फार कष्ट करावं लागायचे आता तेवढं कष्ट करावं लागत नाही हा मोठा फरक आहे त्याच्यामध्ये.
Till the mental health, I think, madam, is rather than we always think the physical problems, but as far as the mental health is concerned, we are still lacking, even as a doctor and even as a patients. They are not that serious because there are some mental issues. Nobody is, means they are finding the solution only in the physical problem, symptoms, diagnosis by doing some test. So
I
it is
think
a reluctant on part of the patient also.
So they are looking at the mental health situation not when it is a problem, but when it becomes a disorder.
Yes, very true.
And that's
Absolutely
only a
right.
tip of the iceberg phenomenon. You're not looking at the hundreds of causes below. So I think it's far important for us. नहीं तो अपनी Titanic sink होने में time नहीं लगेगा.
And that may be.
Sir, there is one more question for Dr. Vishnu. Can I ask Dr. Vishnu here? Yeah,
Yes,
some
ma'am.
insight on GALD, please. Dr. Vikram has asked.
Yeah. So GALD is it is a gestational autoimmune liver disease. So it is like an autoimmune liver disease which is transmitted from the mother to the child. So mother has developed some autoantibodies to the antigens of the liver, and that is how the patient will be targeted by the antibodies from the mother, and most of these children are died in utero. And those who are born will be having a very significant coagulopathy. So they will have a significant coagulopathy. And how do we differentiate clinically? So if we have a serum alpha fetoprotein is very high in lakhs and a severe coagulopathy, and you ruled out the galactosemia and the viral infection. So you have two differential diagnoses. One is GALD and one is this mitochondria. So
This
both can, or HLH, both can be little confusing. But in mitochondrial, you don't see a lot of alpha fetoprotein. But in GALD, you see a lot of alpha fetoprotein, which is very high. And the second, mitochondrial will have high lactate to pyruvate ratio, which will not be there in the GALD. So you do the MRI of the pancreas and you see that iron deposit is very high. And previously, I also used to do the lip biopsies. And the best treatment for them is the exchange transfusion followed by IVIG. And in this series, I distinctly remember one family which were affected by the GALD. The two children are died because of the GALD, and the third child was given the IVIG to the mother from the second trimester itself, from 16 weeks. And the third child did not develop a full-blown GALD, and which was prevented. So getting a diagnosis is very important. And I think this is two things which are required is MRI of the pancreas and very high alpha fetoprotein.
question: can we GALT detect in utero? काही टेस्ट आहे का?
People have tried uh, with autoantibodies in the mother, but not completely diagnosed.
Another question is whether what is the correct age that kids should be given the smartphone?
This is for Dr. Sampada. Official
Ma'am,
age limit to use a smartphone. Like it's like the mothers are giving to children.
true. I think we all would like there to be an official age. It is for people in the office of the IIB to give recommendations to the government so that, actually we can start official ages. Of course, the primary problem is that the parents only will start refuting these problems. Because the moment the child is in 7th and 8th grade, for reasons given like contact करायला सोपं होतं, that mobile is given. So we would always like an official. See, basically we have to understand that screen addiction and substance abuse addiction and alcohol and cigarette, the area of the brain which is getting stimulated is the same below the pineal glands, the hypothalamus. So the earlier you get exposed to it, it is more difficult to get out of the addiction. If you get it after the age of 24, 25, when your precortex is developed, prefrontal lobe is developed, then the addiction would not be great. So ideally, yes, 21 tak theek hai, but कौन रुकेगा 21 साल तक for mobile? Difficult.
पूजा कब कराओ?
Nee, madam, it starts with the Garbha Sanskar only. It starts in
Hello.
utero only.
As thankfully they don't
Hello.
come out with a mobile, sir, nowadays.
Yeah, Dr.
Hello.
Srinivas wants to ask something. Yes, sir.
Ma'am, I want to ask some basic question that every child nowadays is eating with the mobile phone, and she is having some problem with the weight gain. How can we overcome with these issues?
So what we have seen is that I'm sure when you and I were small, चिवकावच्या गोष्टी सांगून काहीतरी दाखवून 10 लोकांच्यात बैठा खेळ करून, we were all, it was community eating and eating as a part of the family. And then you had somebody
Right,
talk to you. So if you have somebody socially, even for us for that matter, if you have somebody who you want to meet, you meet him physically, you are far more happy, right? Rather than meeting that person virtually. Like, I would really love to be in Raigad and talk to you right now, but we are meeting virtually. Fair. The same principle goes through when children are eating. When they are eating with somebody talking to them and showing कुत्र मांजर हे ते असं आजूबाजूचा दाखवून, rather than some silly Nobita on the TV screen, that child would release 10 times more serotonin. And this is being shown as a part of gut brain axis. So if you meet people in life, you are going to definitely produce more serotonin, which is going to add to your happiness, and the child will never actually demand a mobile phone. The problem with the mothers now is that त्यांचं काम सोपं होतं. The WhatsApp university on the mobile of the mother is on, and the internet and the cartoon university on the child's phone is on. So both are happy. Unfortunately, this serotonin is going to give happiness for a few hours. But now what is happening when the mobile is on, it's not the serotonin which is acting, it is the dopamine which is acting, which has a cycle of only 13 seconds. It will give you happiness only for 13 seconds. So one after the other, the cartoon goes on. So that is something, if nowadays parents do understand science, if you tell them that, I think they do come out. So I've tried that, it's
Okay,
come.
ma'am. Thank
Yeah, thank you very
Okay,
much.
okay.
Any
Thank you, ma'am.
questions on YouTube, Pallavi ma'am? Pallavi ma'am, any questions from YouTube? Can you tell? Okay, then we move on. May I request our mentor, Dr. Nimen Mohanty sir, for his comments and declaration of new topics for 1st of May.
No comments. Excellent presentations and excellent discussions. Don't want to kill more time. Topics I have sent.
Yes,
Could you
sir. The
please
first
read out?
topic is evidence-based intervention in autism. And we already got the expert for this topic as Dr. Samir Dalwai, sir. And we are really happy for that. The second topic is about nephrotic syndrome, that is association between exclusive breastfeeding and incidence of childhood nephrotic syndrome. Here we have to finalize the presenter as well as expert for this, but hopefully we will get some top faculty from Mumbai.
That's right.
Tomorrow also everybody should join for the Autism Day celebration. I request everyone who have joined to the today's attendees. Tomorrow also we are celebrating the program with the Sami sirs. And
Before we
day after tomorrow also there is one program with the
Yes.
influencers of the social media. They are the
Yes.
great
Oh.
Bollywood people. They are the great Bollywood people, and they are. The program was on the 28th of April only, and it was postponed 20th of March, and on 3rd of April we are doing that.
Yeah. Now, may I request Dr. Vikas More, sir, our Raigad IIP president, to tell about our upcoming Raigad IIP conference. Vikas, sir, or Dr. Neha, you can. Vikas, sir, please unmute, if possible. On 6th of April, we are having first of its kind conference, a one-day conference from Raigad IIP. It is named as RACE. And we do request all the attendees here to attend it, at least virtually. Any other questions, or shall we close now?
Yes, ma'am, we should. No questions.
Yeah. Will you please give away vote of thanks, Dr. Neha?
Sure, ma'am.
Yeah. Thank you very much.
So today we had a very wonderful session of journal journey with good articles selected by dear Niman Mohanty sir and excellent experts as well as our presenters. I would also like to thank both our experts, Dr. Vishnu Viradar sir, Dr. Sampada ma'am, for accepting our invitation and being the experts for today's journal reading. And your guidance and expertise comments were very, very useful and informative. Thank you so much, ma'am and sir. Very much thankful to Dr. Neeman Mohanty sir, Chitra Kulkarni ma'am, for doing all the hard work behind each session of journal journey, right from selection of articles, presenters, and finalizing the presentation. I would also like to thank both our presenters of today, And I would like to thank MAHAIP President Sir, Secretary General Sir for giving us their platform as well as support. Also Raigad IP President and Secretary for equally supporting this program. Would thank the presenters and thank you Pallavi ma'am for the technical support. And thank you to all the attendees on Zoom as well as YouTube Live for joining us today. So requesting all to please join next journal journey on 1st of May, 9 p.m. Thank you all. Good night.